Otherwise, the other option is for you to join the next session. There will be another session this year. There will be another course this year. Then there will be another uh, hands-on session as well. If failing which, we will discuss. I mean, in the council, what to do. Another online sort of arrangement. Or we will have to study. We have to ask other colleges, so people who are experienced in medical education, about how to sort of give a hands-on exercise via online. So uh, that is in discussion. We'll see what to do. I mean, we will be taking some advices from medical education experts on that. So somebody, how many words? I mean, we have not kept for words because now uh, there are no mandatory this thing. Just take it as a learning exercise. Just try to apply that knowledge, and it can be 1,000, can be 3,000, or can be 10,000. I mean, any this sort of assignment should be around, I think, 1,000 to 3,000 words. That's how usually it goes. But there are no, we just need answers to all those questions. That's all. There are no word limit, not at all. So, shall we start? I mean, there's a slight change today. Tushan is stuck with his work, in the sense he had a bad morning, and now he's stuck with his other work. So, I'll have to cover for him. I'll have to do the Betso lecture as well. So, what do you all want to do first? The about the bed sores or wound prevention? And Dr. Hillary will be joining quite a bit late because he's also stuck. I mean, we have time, but it will be sort of, this will be a bit of a long day. Uh, Anyway, we'll have a bit about 5 minutes break in between. We will do these two lectures. What do you want to do first? Bed sores or wound prevention? Bed sores. Okay. Give me a moment. Hope you all can see the screen. Can you all see the screen?
Yes, it's visible.
Okay, okay. Thank you. So, perfect. So, this will be, I mean, I'll try to be very short. This will be like a 2 hour lecture, but okay, we'll see how concise that can be delivered. So, this is a very important aspect in anybody's practice. So you see, must have seen quite uh, difficult pressure ulcers, I mean, quite very so much destruction of tissue, and it's quite an agony to the patient. So, just first of all, just think about what is a bed sore. It's a pressure ulcer, and it's obviously a discontinuation of the skin due to pressure-induced injury. So, how does it occur? So, basically, what happens is the pressure itself can cause ischemia and then necrosis, or else it can be friction when you push the patient side, try to mobilize the patient from bed to the chair to the bed. That can be friction injuries. Or the patient is a Parkinson or something. The patient is quite restless. Then friction can happen. Then shear. Again, when you are moving the patient, pulling the patient up down, so shear can tear the skin. So this is how basically this is how it comes to be. This is how the initial injury happens. So pressure-induced injury. This is what it's very simply an ischemic ulcer. See, these things are usually seen uh, on a bony prominence. The reason for that is bony prominence is the point which transmits uh, body weight to the support surface, which is the bed or the mattress. So what happens is when the body weight is transferred through the body prominence, it get transferred to the mattress or the bed, and in between there will be sandwiched soft tissue. So skin, fat, muscles, tendons, whatnot. So all that is crushed, and there will be thanks to Newton, there will be a similar force from similar and similar force crushing from down as well. So the sandwich tissue, it has tiny capillaries, so that when this pressure exceeds the capillary perfusion pressure, they get cut off. Then for about 2-3 hours, there will be no blood until you move the patient and let it go. So this is then what happens is these tissues will die of ischemia. So it's a ischemic injury. The skin breakdowns happens secondarily. So is that clear? Is that clear? Any questions on this?
That's clear.
Yeah, okay. It's about body weight and sandwiching between the surface and the body prominence, and it's about capillary perfusion pressure. Exceeding the capillary perfusion, they will be cut off. So you get a ischemic injury. That area ultimately end up with a sort of non-blanching redness, erytheme. So this is a bit of a elaboration of this. Say this happens usually in a patient with high risk factors. So there are various risk factors. So this patient has the risk factors, and the soft tissue and bone prominence, pressure, and then as I said, there will be capillary exceeding the capillary pressure. There will be occlusion and tearing of small blood vessels as well. Then there is this thing, reduced tissue perfusion, ischemic necrosis, and then you get the pressure. So what are the causes? You have the direct causes and the indirect causes. Direct causes, some of them I have discussed earlier: pressure, shear, friction, and immobility itself. Take it as a direct cause. And loss of sensation, combined pathologies can be there. Loss of sensation also adds to the conundrum. Indirect causes, again, mobility problems, poor nutrition, diabetes, heart failure, renal failure, all those things reduce the skin integrity, swelling, low, say, proteins, poor healing, all those things. Aging skin, incontinence, always moisture, mental health conditions, poor self-care, poor skin care, and repeated movements and all that. So those are the direct causes and indirect causes. So now we talk about if you are talking about palliative patients, this is seen a lot in palliative patients. Um, so this is something that can go wrong, and it will go wrong. So it's very common in palliative patients. Or even in the critical setup, the bed-bound patients, this is common. If you don't look at it, it will be missed. So institutionalized palliative patients, the prevalence is about 23%, and there's an incidence about 6.7%. So in home care patients, the reported prevalence is 13%. Incidence is also taken as 13%. Institutionalized ones we are clear, but home care prevalence we don't know whether this is the correct picture. So overall prevalence is about 12.4%. Incidence is about 11.7%. It's quite common. Like more than 1/10 of patients will get it. So another aspect is that once you get this, once your patient gets it, or you receive the patient with a bed, so it's staging. This is the key pillar of planning the treatment. So main thing about staging is once you have defined the stage at the first initial visit or initial consultation, you don't downgrade. If it's a stage 4 ulcer, until it's healed, it stays as a stage 4 ulcer. It's documented as a stage 4 ulcer, healing stage 4 ulcer. So stage 1 is just an epidermal ischemic injury, or just a shear injury or whatever. It's only the epidermis is damaged. So sort of non-blanching erythema is taken as stage 1, or just a shear or a friction injury, damage in the epidermis taken as stage 1. Stage 2 is extending to the dermis. It's a little bit deep. And stage 3 is hypodermis. You see the fat tissue. Stage 4, you see muscle, bone, and all that. Deep. So this is another elaboration of this. See, it's very clear in this one as well. Third stage with fat. bone exposure, the fourth one. So there are two other categories. It's called suspected deep tissue injury. Just a purple or maroon localized area or discolored intact skin. That is, say, there's a ischemic injury. In about 3-4 days, everything dies. So, and it forms a eschar, wet or dry eschar. So that you actually you suspect deep tissue injury, but you can't put into any one of the stages. So it can be a boggy thing, it can be a very dry scar. So just leave it as suspected deep tissue injury. The management is different to others, especially if it's dry. That's unstageable. You can't say what's what. Very so much tissue destruction, and it's old, so it's so gone that you can't understand what's what. So you just see a lot of pus and slough, let's say. Yellow, tan, gray, greenish, brown, everything is there. And there is about 25% of a scar, and that sort of picture you can't actually stage. So just leave it as unstageable. So can anyone stage this one? There are two lesions. Anybody?
The lower one is stage
Yeah.
3 and
Go on.
the upper one is 4.
Stage 3.
Stage 3.
3 and
And the
4.
upper one
As
is
muscle is not exposed, it is stage 3.
Yes, 3 and 4.
Yeah. Yeah. Four, top one, 4, I agree.
4, yeah.
Yeah. Now see, lower one, just see now, see, in the top one, what I'm pulling is actually the gluteal muscle. So this, I think it's still the same. This is the so this sort of in the middle of the lower one also, that is the gluteal muscle. So that makes it stage 4. You can clearly see the fat layer, yes, but the what you see like similar to slough, that is actually sloughing out gluteal muscle. So it should be 4. So what about this? Just take it as a single lesion.
Stage 3.
Is it?
Stage 3 because muscle is not exposed.
stage 4.
It is a 4. See, you can see the muscle.
Yes.
See, quite deep, sloughing out muscle. And there was bone as well. I mean, you can't appreciate the bone here, but it's stage 4 again. So this is the model we are proposing to as the approach to bed sores. We call it look, and look again. So let's see what to look for. So first, you look at the patient as a whole. We've been talking about this during the last few weeks as well. So you have to take the patient as a whole. So identify the intrinsic and extrinsic factors that may lead to pressure ulcer development. That's why those things we have discussed those things. So that's clear. No, just try to understand what are the risk factors that this patient has, intrinsic and extrinsic stuff. So you look for the nutritional status. mobility, extremes of age, sensory impairment, how much pain the patient's in, the illnesses, whether they are chronic, acute, or terminal, whatever the illnesses the patient is having. If it's a terminal illness, of course, there's a sort of a bias towards maintenance rather than cure. So that's another thing to note. And any vascular diseases, mental health status, level of consciousness, and previous history of pressure damage, which will actually put him up in the scope of risk. So, and you see signs of pressure, shearing, friction, lot of moisture with the incontinence, and so poor moving and poor handling as well by the caretakers. And the medication that might hinder healing, hinder the skin integrity, make it dry, make it thin. So that sort of thing. Imagine a patient who's on steroids and multiple immunosuppressions with a kidney transplant or something, or otherwise somebody with an autoimmune disease, or someone who's been treated for rheumatoid arthritis, that sort of situation. So medication is important, and even the level of, let's say, poor moving and handling as well. So second thing to look for is look for the level of risk. Assess the risk with a standard scale. So easiest to learn and easiest to use is the Norton scale. This should be done at the entrance to the institution, if it's an institution, say at the admission to the ward. Then at least every third day they should be updated. Ideally, it should be done daily. So physical condition, mental condition, activity, mobility, incontinence, all that is assessed. Lower the score, higher the risk. So Norton scale can be adapted. So if you are doing, say, home visits, or if you are treating patients with bed sores or bed-bound patients, you should use this the first instance and each and every repeated visits. So the other thing is there's another scale called Braden scale, quite similar, but it has more data. So again, sensory perception, moisture, activity, mobility, nutrition, friction, and tear. So lesser the score, severe the risk. I think Norton scale is quite easier to remember and quite easier to use. And third one to look for existing damage of prone areas. So identify the pressure points in patients' usual lie and movements. So this is an elaboration of how patients might be positioned. So you all must have seen some of these points getting ulcers, but you might miss the ear, side of the head, maybe the leg, ankle, thigh. Even thighs can have, yes. Knees, breasts, elbows, cheek, and even in the seating position, you can have bed sores. Back of the head, shoulders, lower hip, sacrum. So quite common. So hope you all can remember this. So these are the points to be looked at. So another one. So shoulder blade, lower back, hip, even the heel. When the patient is even lying supine or on a wheelchair, if it's a wheelchair bound patient, they might have a heel ulcer. And look again means look what can be done for the identified problems. That is the management and preventive plan. So this is a proposed care bundle by Ferris et al., Keith Harding, and all these people from Cardiff. So see, risk assessment, skin assessment, skin care, nutritional assessment, activity management, moisture and incontinence management, support surfaces management. So risk assessment, we know upon admission or within the first 8 hours, then daily, or if there's a change in the patient's conditions. So skin assessment, head to toe, upon admission, then every 8 hours. You look for heat, color, turgor, level of moisture, edema, redness. So you must always look for the look especially at the skin around and underneath medical devices every 12 hours at least. That is very important. So skin care, what do you mean by skin care is protect the skin with barrier products. Keep it clean, normal moisture. Ideally, the skin should be cleansed with pH stabilizing products. Do not rub strongly, just very smooth application. Do not massage. If you are massaging, don't pull and massage. Just squeeze that area, go to the next one and squeeze. So sheet should be kept clean and stretched and dry, no wrinkles. Before the patient is put to the bed, there should not be any wrinkles because they can cause friction and shear. So nutritional assessment. So daily nutritional goals should be done. So, you have had a lecture on this. I think you are fluent on this by now. So you have to be meet the daily goals and so this is important because there are certain certain patterns of wounds that happen in various conditions of derangements in the kinetic chain, and especially the Achilles tendon, the position of the Achilles tendon. So whatever footwear you advise will affect all that. Whatever changes in the footwear you advise, say if you are cutting a hole or putting some rubber bar somewhere, expecting it to elevate the wound, offload the wound, all that affects the kinetic chain. You just have that in mind. I mean, I'm asking not to avoid all that. You should do that, but just have that in mind because the complications might occur. So, why do our patients, the patients with diabetic foot wounds need special shoes? Is that they have neuropathy, they can't feel it, and they have foot deformities, and they have fat pad problems, they migrate everywhere, and all that leads to wounding in this foot which carries us around, hitting all hard surfaces. So footwear can actually be a wound healer. So in this wound, that's a dry scar. Didn't use much, just a offloading footwear, and see the before and after. It just fell off, and basically no dressings. And all the toes are also okay. So it's a little bit about the parts of a shoe. Remember, there is a outer sole, and forget about the others. There's an insole. Insole is the one you can do adjustments. Insole is the one that is touched with the plantar surface, and there's a heel counter. It should be stiff, and the outer sole, of course, again it should be hard a little. Nothing should penetrate that, and the insole should be soft. It should take the shape of the shoe, shape of the plant aspect of the foot, ideally. And the toe box should be wide enough to accommodate all the toes with comfort, or if there are deformities, all those deformities. If there are gross deformities, better to avoid covered shoes, better to use sandals. So diabetic shoes have good wide toe box and tough heel count, as I said, tough and lightweight outer soles, and Velcro to adjust all the straps, and padded inner surface to avoid friction and shoe cuts, and extra depth for accommodating insoles, customized insoles with changes. So you don't need actually all this. So the shoe size must be the correct size, always the correct size to the say if one foot is dressed with a dressing, they can use the other foot. Or if there are like 4-foot amputations or any other amputations, whatever the size that matches, they might have to get 2 pairs. So correct size for that foot. And always they should walk around and see before buying. So let's talk about that. So again, prevention of bed sores I have put here because it's part of the thing. Little bit about stomachia because that is also wound prevention. I think Hillary will talk about this. Let's see whether he's there. Shehani, are you there?
Yes, I'm there.
Can we ask Hillary to join
Okay.
or what's his situation? Because yeah, I
Right.
can just do this and finish off. Otherwise, he can carry on.
Right, okay.
Okay. So let's just keep stomachia for the moment. So a little bit about venous wound prevention and management of swelling, the edema. So those are also important aspects of wound prevention. So to talk about venous wound prevention, if you see lipodermatosclerosis, any changes, always advise the patient to get those done, get the varicosities done. go to a general surgeon who does it, or vascular surgeon, or get the whole thing done. If you otherwise, if you can inject, if you are sure you have get a scan. I mean, if you are really skilled and if you are trained only, you should do that. Safest bet is to ask a vascular surgeon. So get it done because changes happening means eventually there will be an ulcer. So after that also they should wear some good stockings, and there should be extra care about that area of this iron toxicity. So moisturizing, a little bit of compression, and barrier coverage from the again applied from the compression bandaging or the stocking. So a tiny stretch or a tiny tear of skin can go a long way. It might not heal for 30 years. So it's very important to prevent venous ulcers. So again, skin care, compression, and getting the veins done. And veins will recur. Once they recur, they have to get it done again. And about lymphedema, mainstay is compression. And there are ways and means of massaging, getting the fluid into the abdominal cavity slowly, and elevation of foot end elevation, and there are compression garments as well. But anyway, compression is grade 2 or 3 compression. If they can tolerate, grade 2 or 3 compression stockings also will do. And there should be extra care about toe webs and other skincare measures that we spoke about during the foot diabetic foot ulcer prevention. All those also will apply. And lymphatic correction surgery is actually cumbersome, so don't ask for them. Just carry on doing the basics. Skincare, compression, massages, and elevation. You will see a drastic difference in your patients in about 2-3 months. And if the patient has had more than 2 episodes of cellulitis, you should have add benzathine penicillin or oral low dose preventive C penicillin. So I think I covered most of it. Are there any questions on wound prevention? Yeah, how to manage a chronic wound with chronic lymphedema? Yeah, first thing is you just understand the wound bed. These wounds, I mean, these chronic lymphedema wounds are very fibrous. So how to get to the fibrosis, as I think Prof. Mandika's session, that webinar, he said just remove the fibrosis and get some new granulation tissue. That is one way to manage the bed. Or otherwise you can use papain or whatever to get as much out. And if there's a biofilm, you have to address that. Those are the issues with the wound bed. Say they have an ideal wound bed, then it's management of lymphedema. So there are ways to compress. There are ways there are methods that you can use to Foley bandaging, or using 2 crepes maybe, or bandage plus compression stocking. So whatever means necessary, you get the compression. So compression is the mainstay, and all the others also come in. Say massaging, elevation, all those come in. So once you have managed the lymphedema, the wound will start healing. But the problem is with time, they will be having a lot of fibrosis. Explain regarding varicose veins and tube grip, how we can find the time. I don't understand this question. 96 WC 20C 96. Please explain regarding, I think V veins means varicose veins and tube grip. What do you mean by that? Tube grip is not varicose vein treatment. Tube grip is just shape support. It doesn't give much compression. Compression is given only by class 2, this class 2 compression, class 3 compression stockings. So those you can apply to people with varicose veins. But I don't think anybody would like to wear such an expensive one with an ulcer. So it's the ulcer is basically bandaging. So are there any more questions? Shehani, is Hillary there?
Sir will join in 5 minutes, it seems.
Okay,
I
good.
inform, yeah.
Okay. So until he comes, are there any questions more? At GP setup, how can we give local anesthesia for wounded bite? You can, I mean, you get a good allergy history. If you are sure enough, you can do. If you are fluent in the wound debridement, of course, because and the other thing is you have to be very sure that the patient has no vascular compromise. Once you cut, you are in a soup. So other thing is if there are any say complications, say the anaphylactic reaction or say lignocaine overdose, that sort of a thing, you might have to have oxygen and all that ready and all that. So in a good setup, you can do it. And if you manage those patients in the hospital enough, if you are experienced enough, you will know which patient can give problems and which patient won't. So I think it can be done. Did I answer your question? I don't know whether it's what you asked. And local anesthesia for wounded body, actually, say chronic wounds, they are mostly numb. You can, it's not necessary for diabetic wounds, especially. You don't need any anesthesia. So topical anesthesia, I don't know whether they work. It doesn't usually work. So just get a good rapport with the patient and pull the slough away. Can you explain little about management of a chronic wound with maggots? Some people use turpentines. Good for evidence. Yeah. So maggots are, I mean, as Prof. Mandiko said, maggots are good. So you should not be afraid of maggots. Maggots will never eat the normal tissue. If there are maggots, that means the wound is not it's not that not that it's unhealthy. It has necrotic tissue. They will eat necrotic tissue and slough. So practically, what I do is I use turpentine is corrosive. They are the maggots actually they go for they go to these crevices and undermining and tunnels. So just probe those and take them out. But the easiest is to give them some dextrose and leave the wound. Just put some dextrose and leave. So those really hungry fellows they will come to the you just remove it and take them off. Rest you just pull them off from the crevices, and if there are then you should wash with at least betadine or something, then that will also be corrosive. So you can get a good cleanup. You wash it properly, or even tap water with good pressure, that can also be done. Turpentine will kill, I guess.
Dr. Tusita, Dr. Larry is available now. You
Okay.
made him
Then,
co-host, yes.
yeah. Okay. Then, yeah, I was just answering these questions to give him some time. So then I'll stop. So this will be the last lecture. So thank you very much for bearing with us, and thank you very much for listening to us. And all the best of luck. And over to you, Hilary. Thank you very much for joining at this late hour. And I know you are really exhausted with your work. So thank you very much. And over to you.
Can you see the screen?
Yes, we can.
Can clear. Yeah.
Right. Right. So my focus will be on stomal care, with special concern to this wound healing, because now we need to maintain the nutrition and also to evacuate the bowel and urine in a safe manner, so that these contaminating agents won't persistently irritate wounds that leads to poor wound healing. So it's important in that aspect to maintain the nutrition and also to safely evacuate the bowel and the urine away from the wounds. Right? For example, the bed sores that are in the perineum, in the sacral region, they get frequently contaminated with stools and urine if these products are not contained and taken out properly. For wound healing, you need proper nutrition. So if somebody cannot take feed, these are the options: NG feeding, PEG feeding, jejunostomies, and there are various options. So these are like nasogastric feeding, percutaneous endoscopic gastrostomy, jejunostomy, which can be open. And then the stomas. So we have small bowel stomas and large bowel stomas. So for evacuation of bowel, the commonest one we use is the ileostomies from the terminal ileum. And then also the colonic stomas, we call them colostomies, It can either be in the ascending colon, transverse colon, descending, or in the sigmoid colon. So they can either be, these are also important for managing enterocutaneous fistulas. Right? These are very cumbersome and bothersome diseases to treat. So in such instances, you divert the fecal stream above the stoma so that the fistula, so that the fistula itself heals in a conservative approach, right? So these show that this is a jejunostomy here, xylostomy, ascending, transverse, and sigmoid colostomy. Now, when we talk about small bowel, small intestinal stomas, we make them sprouted so that the irritant material coming out, the enzymes that are irritant and digestive in nature, don't get into contact with the skin. If that happens, it causes erosion and irritation of the skin. To prevent that, we make a small sprout-like outpouching of the stoma so that the appliance or the base plate can be fixed in such a way the irritant gastrointestinal secretions don't come to contact with the skin. So this can be either end stoma or a loop stoma with two openings. One side, it will be draining the fecal stream out. Then the other side remains like a mucus fistula, right? So the Hartmann's or like, so this is an end colostomy on this side. And also there are certain special stomas draining urine after you remove the bladder and reconstruct the lower urinary tract by means of a distal ileal loop. So again, this is also a sort of a sprouted outpouching so that the urine can be collected into the bag easily. So again, an example of sprouted ileostomy, end ileostomy and a looped ileostomy. And here in the lower picture, you can see how a bag, either single piece bag containing the base plate and the bag together, or sometimes this can be two piece. The base plate sits on the skin and the bag can be attached to the base plate as a second piece. So there are different complications, early versus late, bleeding at the site, high output stomas, high output in the sense like the fecal output or the stomal output is great. So the patient can actually go to dehydration and fluid electrolyte imbalances unless they are treated properly. Stomal ischemia, stomal retraction, obstruction secondary to adhesions. The late complications are obstruction, dermatitis, intersusception of the bowel, prolapse, parastomal hernias, stenosis, fistulas, connecting the stomal bowel with secondary skin fistulas. There are psychological and failure needing to reposition the stoma in the long term. So these are few complications. You can see once the irritant gastric juice or the intestinal fluids come into contact with the skin, the whole skin gets macerated, irritated, and gets wet. This is a stomal fistula where the abnormal connection is there between the stomal bowel loop and the skin. The stomal retraction part of the stomach gets retracted into the skin. Stomal prolapse, where the normal decent looking sprout is actually jutting out like a trunk of the elephant. And the stomal ischemia is easy to diagnose. Of course, the otherwise pinkish stomal mucosa gets dark and black and looks pretty much dead. So the common reasons are the extensive skeletonization of the bowel and obese patients when there is significant traction and tight parietal fascial opening. You need to excise and refashion. You can see the pink looking nice stoma versus black necrotic stoma here. Again, stomal retraction is again, you can see the stoma getting into the skin, loss of the sprout. You may have to go for revisional surgery in this as well. These are common in morbidly obese patients with a lot of fat in the subcutaneous area. The twisting of the bowel. Sometimes the bowel can twist once it comes out, and then you need to identify by means of imaging, and we have to do revisional surgery to correct it. Then the parastomal hernias. These are the herniation of bowel loops parallel to the stoma. Then the stomal prolapse. Again, all of these needs revisional surgical procedures. Then the bowel obstruction, secondary to surgical procedures. Then the peristomal skin problems, irritation, ulceration, desquamation, and abscess formation. These are mostly due to the caustic enzyme-rich small bowel content. And then the management is to go for a proper sprouting at the time of the surgery, and the proper stomal care, well-fitting stomal appliances, and the barrier creams in containing zinc and barrier creams, such as common thing that we use is ones we use for nappy rashes in babies. Right. So these are also a few examples of these excoriations and ulcerations. So the fistula formations are also common in certain disease conditions like TB, Crohn's disease, and some malignancies. So you need to recite or revise the stoma in such instances. So intracutaneous fistulas are also a very common, very difficult to manage condition. Fistula is an abnormal connection between the bowel loop and the skin. And these are common in places where we can't close the abdomen properly, such as in increased abdominal compartment syndrome. And once you can't close, we close the abdomen in method called laparostomy, and we allow the granulation process and subsequently maybe skin grafting and various other techniques. But in the interim, the bowel loops can get opened into these areas. So the wound healing becomes very problematic in such situations because the wound is constantly bombarded with irritative substances. And these are few ways of managing, right? To fix the appliance or the base plate and contain the fluid output while the negative pressure is there to enhance the granulation tissue formation. And so it's sort of a controlled drainage of the intracutaneous fistula. So when you advise a patient, how would you advise the patient to empty the stomal bag? So 1/3 is the ideal time to empty. So there is ample time for the patient to go for a suitable place, maybe a toilet or a personal space. When it is half full, you're still good. But if once it fills 3/4, so like 75% of the bag is full, you're impending a disaster. The bag might get accidentally disconnected due to the heavy fecal load, and it may contaminate the whole wound or the abdomen, and it can be really messy. So we advise once the bag is filled 1/3 to half, you have to empty the bag. So those are the methods to divert stomas for fecal diversion. So it's very important in managing persistent wounds of intracutaneous fistulas, laparostomy wounds, and also large bed sores in the perineum, maybe ulcerating carcinomas, or bed sores due to pressure sores in the perineum, in the vicinity of the perianal and sacral regions. So the continuous contamination is minimized and proper wound healing environment is provided for the wound to heal and fill from inside out. So similar sort of diversion of urine is required when there is persistent leakage of urine onto the wound. So from the upper tract, we have externalization of urine by means of percutaneous nephrostomies. It can be by a temporary measure with a pigtail catheter, or a more permanent sort of a Foley catheter type nephrostomies, which can be easily changed over a long time. Stents, there are normal polyurethane stents, reinforced stents with metallic reinforcements, or purely metallic stents are also there, so that these stents become more patent, and the patency retains for a longer duration, even with malignancies. And then there is surgical diversions with ileal conduits or colonic conduits, similar to the stomas we use for fecal diversion. We can use either ileal or colonic conduit to take the urine out of the body in a surgical manner. So those are surgical diversions. So for the lower tract obstruction, say for example, prostatic cancer or radiation-induced stricture and multiple fistulas draining into the perineum, contaminating perineal wounds. So then you can divert the lower tract by means of a suprapubic catheter or an indwelling urethral catheter, or if the patient has better vision and mobility with hands, he or she can do continuous self-intermittent catheterization as well. There is a outer sort of like a wearable catheter called condom catheter. When the patient is incontinent and the bladder is low pressure, you can put the condom catheter to drain urine without being contaminating the wounds. Then there are neobladders. Neobladders can be positioned in the place of the bladder. Those are called orthotopic neobladders, or neobladders made of either small bowel or ileocolic segments that can be positioned in other places other than the original position of the bladder. Those are called heterotrophic neobladders. So the retention of urine, you can see a hump in the suprapubic region. You can simply drain in an emergency if you can't put a suprapubic catheter by means of inserting a large bore long needle above the pubic symphysis onto the bladder. Make sure the bladder is palpable and there are no surgical scars which may give rise to adhesions of the bowels into this area. So this is a suprapubic cystostomy set you see here. With that you can insert the SPC catheter. So this is a condom catheter where you wear outside the penis. This is the intermittent catheter, the indwelling catheter with the balloon. There are different retaining mechanisms in these as well. This is again a condom catheter. So this is what I told you previously, the nephrostomy drainage. The pigtail lies within the pelvic calcareous system and goes through the renal parenchyma and comes out of the skin. So there are different types of stents, as I've told you, polyurethane stents, metallic stents, metallic reinforced stents. Various stents are there so this is anti-reflux stent, right? Again, the nephrostomy is more permanent nephrostomy tubes. They come in different shapes and sizes with different balloon configurations. So all these are various options where you have for draining urine out of the system to prevent contamination of the wounds. So say perineal wounds, for example, ulcerating penile cancer or ulcerating labial cancer where the entire perineum is like a cauliflower and you can't figure out from where the urine is coming out, then you may have to either put a suprapubic catheter and drain, or maybe to drain the urine out from upper tract with nephrostomies. Then again, there can be ulcerating carcinomas, for example, cervical CAs, ulcerating into the ureters. There can be ureterovaginal fistulas, can lead to sepsis. So then you have to drain the urine above from the upper tract to prevent urine coming from the distal ureter into the pelvis and the pelvic collection, and to prevent the sepsis there, and resuscitate and treat with antibiotics, and then to allow proper wound healing. So in different settings, curative versus palliative settings, there are different options we use to treat these situations in stoma care. So these are few things I would like to highlight, especially in the wound healing and in care of the wounds. You need to divert the fecal stream away, the urinary stream away, depending on what sort of contamination is preventing the proper wound healing process. Any questions from the audience? Hello?
Anybody, please ask questions. I mean, these things are not usually incorporated in the wound care certificates. Also, these are real
So how we manage?
gems of get the most of this. Yeah. Go on, yeah.
So how we manage peristomal maceration?
Yeah. So depending on the site and depending on what sort of problem is there. For example, it can be due to a poorly fitting device. Then you need to cut the inner ring just adequately for the stoma to come out. And then you need to fit the proper device to prevent leakage. Maybe it comes with the sort of like a belt. So the stomal bag is held in place tightly, so it won't leak. So various options are there. There are barrier creams which come in various stomal companies. And also, if it is not there, then you can use even a simple nappy rash cream like Q-Rash, even if you can't find a proper colostomy barrier cream. That also is good enough to keep the moisture away and the enzymes away, and to allow the underneath skin to heal. There are if you say take Coloplast or various other these companies, they do have their own specific wound care devices and barrier creams and powders containing zinc and various material that help to heal the skin maceration quickly. So those are the things that we can do, from tight fitting of the device to prevent the stomal bag from leakage, and to prevent the skin getting into contact with this irritant bowel contents. Anything else? Any further questions? Now, this is, as Tosita said, this is little beyond the wound care management at your level. But then you need to know when to seek help from the surgical departments to help the patient heal their ulcers or wounds in these difficult areas. So the whole idea is to let you know when to refer for a diversion colostomy, ileostomy, or a urostomy, right? So there are different ways and means of doing it. There can be minimally invasive ways. There can be open techniques. Depending on the scenario, the treating team can select those. But as physicians treating ulcers and trying to help the patients get rid of their wounds, you need to know the options, right? So that's what I have tried to do during this lecture.
There's one question in the thread. Do you recommend powders for peristoma skincare? Obviously there are powders for that as well. So the core component is actually zinc containing barrier powders. They can be used. Whatever you can use, that is what I said. Like, even if you can't find a stoma specific sort of a thing, even like Q-Rash or anything like nappy rash sort of a thing can also allow to separate the irritant from irritating the skin. It doesn't have to be
specific thing. Whatever the patient can find, whatever you can find, can be utilized. You just need to know the theory behind it. You have to separate the irritant from further irritating the skin.
Yes, another question, Hilary. Can condom catheter cause pressure ulcer with repeated friction usage? If so, how to minimize?
Condom catheters can actually lead to like the condom catheters are being held in place with plasters. So the plasters can actually give rise to sort of like traction injuries and then scarring. Yes, that is possible. But if that happens, then you have to go for some other option because the same place is going to be irritated again and again when you use the condom catheter. Oh yeah, the chat has these questions, right?
Those are the only two
Yeah,
questions.
that's all. Are there any other questions?
So if patient is having indwelling a urinary catheter with the tip of the penis ulcer, what is the management steps you recommend?
Yeah, so that happens with traction, and this is actually a pressure ulcer at the tip of the penis. So it often happens in the lowermost corner. Because of the gravity and the pressure, the lower part of the external meatus gets ischemic and it can give rise to even sloughing of that area. What happens is either you can place the catheter, if the catheter cannot be removed, you can change the position of the catheter. You can keep the catheter upward and apply a plaster there so that the pressure won't be sitting on the same area where the ulcer is, because we want a good blood supply to the floor of the ulcer for it to heal. Then the ideal would be to take the catheter out, or maybe to put a suprapubic catheter in the interim to drain the bladder. So then that gives, that prevents pressure from pressure being exerted on the ulcer area to enhance the blood supply to the floor of the ulcer. So those are the things that we can use. And even like sometimes where we come across patients where the suprapubic catheter by virtue sits little higher. The tip of the catheter sits little higher, whereas the bladder neck lies in a lowermost position compared to the suprapubic catheter, and the patients can still drain urine through the urethra. So then sometimes, rare occasions, we have to go in and close the bladder neck by putting a stitch so that it won't come out, or divert from way up, like nephrostomies to drain the urine from upper tract itself. Anything else, guys? You just need to know when to seek help. You have to realize that urine and feces irritate wounds and prevent wound healing. And then if that happens, you have to divert it. You need to get the help of the relevant team to divert the urine or the fecal stream above the wound. I think that's pretty much it. No further questions.
I think you have done excellent lecture, so they are maybe not like kind of understood very much, and the people do not have much queries about it. That's great.
Thank you, madam.
I think today is the last thing, no, Tusita?
Yeah, madam. Yeah, this is the last session now.
Last session,
Last day.
Hmm.
So,
Can we develop this resource pool with them? I mean, are they willing to be with us as a resource pool? Because we can develop the resource pool. In fact, I mean, they can support some community kind of things. Some, I mean, wherever they work, most are not in Colombo, no, outside the things, no. Isn't it?
yeah, we have to develop this into a sort of alumni. We have, I think, 300 odd people now, maybe 400
Yeah.
doctors. So you can have an alumni. Now there's one other movement also going on, Wound Warriors. That
Yeah.
is, Tushan is formulating a group. So I think at some point this alumni can also join up with the Wound Warriors. That is from the Faculty of Medicine certificate. So
So then there is
I think first thing is for us to organize everybody into this thing. So it will be then very easy to update everybody at once. And if there are any problems, so we can share our experiences and questions and discuss patients and all that.
Shall we develop the group like our palliative alumni, and then in fact, I spoke to these e-channeling people. They also kind of willing to kind of support it. Something like that, because there are a lot of people in the community who need support. No, I mean, if they are coming to the hospital, then you can, and Hillary and all, I mean, all them, Pixie and everybody can support, but some are in the community, and I think from their vicinity, they can help them, no, in such way. If we develop the resource pool.
Yeah, we should do that, madam. Yes, definitely. So this year, I think it's a good initiative if we can start it this year.
Yeah, we will try to do. And the other thing is, this year we thought that we will have a certificate ceremony, no, isn't it? For the,
yeah.
And the physical ceremony we want to have at SLNMA this time.
Yeah.
As soon as your assignments are finished and everything is finalized, we will inform maybe in April. No?
Yeah, in April. That's the plan. Yes.
Yeah.
So April, early May or April, end of
something.
April. Yes, sir.
Okay.
Yeah. So there will be a certificate handing of a ceremony. So
with the Ministry of Health and the things that
so will be probably held at most probably it will be at the SLMA.
Auditorium.
Yeah. So we'll then let's wish best of luck for them, no, madam, that they can complete the assignment.
And thank you for joining, because we might not meet them, some people again, because some will meet in the hands-on training, but all have
Saturday
are joining for hands-on training. No? So, but others, thank you very much for joining us, and we hope that you have learned quite a lot, and then updated your knowledge. And this is not the end of the story. We want you to be with us as a resource pool and to help the people in the future.
Yeah, and good luck, and thank you very much, madam, for leading this whole thing. And this is the first time that we have done this early course. Usually it's in July, ending up with the sessions. So bit of a rushed course. Now this time we have time. Good lectures, and it was all everything was up to today. I think
all this thing, Dr. Kahadu and Dr. Hillary and Dr. Gitsiri and Professor Mandika and Dr. Kushan. I think everybody will be great.
Dr. Anga. actually, Prof was actually a good supporting hand. I mean, basically, all these lectures are his seeds and plants of Mandigas. So it's yeah, we should, I mean, give big thanks to him. And Shehani for organizing all this, and the IT, I can't remember. I'm sorry, so sorry that
Yeah, Sashna and Shihani
Sashna,
have
yeah.
done a great job with
Yeah,
the
so
good
that's great job, well done, and thank you very much. And, Saturday, try to come at least around 8:30, and you will be divided into groups. I think Shehani will put up the groups, and stay with the group. Please move with the group, and we'll see how it goes. I mean, a bit of a rush because I'm handling this much of doctors at once is quite difficult. So there will be time delays, add-ons, and all that. So let's try to do the best. No,
Yeah,
madam.
we'll try to kind of plan and do the smooth running. Don't worry. Yeah, yes, we will be there. No? Yes, we will try to do the smooth running.
Okay, then and yeah, well, let's call it a day now. Thank you very much.
Yeah, thank you then. Well, everybody, good night.
Good night and best of luck.